Welcome to the Practice Impossible podcast with your host, Coach JPMD, and that's me. And this episode is a little different. It's introducing a new concept in what we've done over the past couple of years, and that is to actually summarize one of our important series that we had in season 1. As we prepare for season 2 and the release of new episodes, we wanted to summarize the Money Tree series, as we feel that it's important for physicians to understand the flow of money and how monies flow from CMS, Medicare, to Medicare Advantage plans, to IPAs, and to provider bank accounts. So we've chapterized, if I can coin a word, I think that's a word. And basically, we've created chapters with all the Money Tree series in one episode. And we hope that you enjoyed. Click on the link below, and you'll see the episode. And you can listen to all the things that we talk about with regards to money. In the meantime, as we prepare for season 2, we're really excited with the guests that we have lined up. And we hope that you hit follow, subscribe, whatever you do in your podcast app to get alerts for new episodes. See you soon. How physicians get paid. How physicians receive monies from the government or an insurance company to their bank accounts. So in this series, I'm going to detail and break down each aspect of the payments that we receive as providers from the Center for Medicare and Medicaid Services. Insurance companies receive this money from the government to pay providers. So in this episode, I'm going to cover 3 things that providers should know as they run their practice, see patients in the hospital, and just practice medicine in general. So I know that some people are visual, so I also created a sheet, a 2-page sheet that details the money tree, what we call the payment tree in the LAMA course. And that money tree will depict every aspect of the payments that are distributed from the insurance company to the providers. You can go to www.coachjpmd.com/moneytree to download that 2-page sheet. So you can download that for your reference. So why am I doing this? So I'm doing this because I've got a lot of feedback from those who've been listening to the episode, the Practice Impossible episodes, and they've told me that they wanted to hear more about the finances and the financial aspect of practicing medicine. And I thought it would be great to help you understand a little bit of what I didn't understand 20 years ago when I first started. So to begin the series, I wanted to start at the root of all payments in a Medicare Advantage program to providers, and that is the Center for Medicare and Medicaid Services, or CMS. So there's 3 things I wanted to cover in this introduction to the Money Tree series, and that is CMS funding. So how does the Center for Medicare and Medicaid Services receive its money? Where does it come from? How is that money distributed to the insurance companies? And number 3, what can increase or decrease payments from CMS? So I'm going to try not to get into the weeds here and give you a basic overview of how Medicare is funded. For those that are interested in the weeds, I'll put some links in the show notes to guide you as to where you can get the details of how Medicare is funded. But the main aspect is through a Medicare trust fund. And this fund is paid for and held by the U.S. Treasury. The first trust fund is the Hospital Insurance Trust Fund, and that's paid for by payroll taxes, paid for by employees, employers, and people who are self-employed. And then there's also some sources of income based on Social Security benefits or income tax paid on Social Security benefits and interest earned on trust fund investments, as well as people who can't afford the Part A premiums or the hospital benefits who pay a premium to have that coverage. Now, there's a second trust fund is the Supplementary Medical Insurance Trust Fund, or the SMI. That's funds authorized by Congress, and it's premiums from people who are enrolled in Medicare Part B, which is the part that covers non-hospital related expenses, and premiums paid for people who are covered in Part D, which is the pharmacy benefits. And of course, the other source is interest earned on those trust fund investments. The second thing I wanted to talk about in this series, or in this intro to the series, is how the funds that CMS has in their trust funds are distributed. And so there's two main ways. There's either a fee for service, or you pay a provider for services rendered for the insured. So those that have Medicare, typically those that are 65 and older or disabled or on dialysis, those payments are made directly from the government to the entity or to the providers of care. So that would include physicians, hospitals, radiology centers, durable medical equipment companies, pharmacies. And so these payments flow from CMS to the provider directly. Now, what I do in my practice is contract with a managed care organization. And those managed care organizations receive payments from CMS, and then they distribute the funds to the primary care providers, the specialists, the radiology centers, the hospitals, the pharmacies, and those are typically private entities. So monies flow from CMS to the insurance companies via a direct route. So Medicare pays that physician directly, or a managed care route, or a Medicare Advantage company. And those companies are usually private entities. And there's a third way, and I just thought about this, somewhat like a direct route, and that's through the accountable care organization. So there are ACOs that can also manage monies coming from CMS to the providers, and that is the entity in between CMS and the providers of care. So really there's three main ways, but the majority of payments flow via the direct way, fee-for-service, or managed care. Now, the third thing I wanted to cover was how can a provider increase or decrease payments from CMS? So in a direct route, it's really not possible, because CMS has a fee schedule for providers that provide care for their patients or the patients enrolled in Medicare. And there's really not much room for an increase in payment or a decrease in payment as well, unless Congress authorizes an increase in payment to the providers. Now, that's in the direct route. So in the managed care branch of the tree, if payments are made to a Medicare Advantage company, those payments are typically in a pool that's distributed annually based on the government's formula of distributing payments to managed care organizations. So if a managed care organization does well by providing quality care and increasing their quality scores, and you'll hear me talk about HEDIS scores in future episodes, those HEDIS scores can help managed care organizations receive more money from CMS. And the other way is to have a patient population that's sicker than another managed care organization. So sicker patients tend to cost the government or any insurance company more money, and the government is aware of that, and payments can be increased if patients are coded with certain chronic conditions that will end up triggering the increase in payments. So there are two main ways to increase payments is by coding in a compliant manner chronic conditions, and also making sure your quality measures are met and preventative measures are scheduled for the patient, like screening mammograms, bone densities, colon cancer screening tests. And those are things that can increase payments to the managed care organization. At the same token, if you don't do well and your quality is poor, then the government will decrease payments to that organization, which could lead to less payments in your bank account. So I hope I didn't get too far in the weeds here, but I wanted to kind of summarize what I've discussed in this intro to the Money Tree series. That is the three things that every provider should know about the root of the payments that they receive from the government. And that is, CMS receives its funding by way of two trust funds that were set up, one being funded by payroll taxes and the other by Congress. Number two, distribution of CMS funding to managed care organizations and fee-for-service contracted organizations or providers are the two main ways for physicians to receive payments from CMS. And there's two main ways you can either increase or decrease payments from CMS, and that's through improving your quality scores as well as improving documentation of chronic conditions. So when you look at that payment tree or that money tree, you'll see that there are different entities in each branch of that tree that we'll be talking about in this series. So future episodes are going to be about different branches of that tree. So we started with the root, then we're going to go to the trunk, and the trunk is going to be the HMO or the Medicare Advantage company, or even the private payer if you're not dealing with the government. And the next is going to be the IPA, MSO, or intermediary company that interfaces in between the provider and the insurance company. And then the next several series is going to be about each individual provider and how monies flow to them. So I'm going to try to make it fun. I'm going to try to make it relatable to you because these are things that I didn't know when I started. And I wish that I had someone guiding me because that probably would have accelerated my growth. So I'll also try to have some guests on the show to discuss the different aspects of the money tree. In the meantime, download the money tree diagram that I created for you guys at www.coachjpmd.com/moneytree. So I know there's some of you out there that is pretty stressed out about finances and stress and really not really knowing where to go in the practice of medicine. And I want to give you an opportunity to book a call with me for 30 minutes if you want to learn how I've managed to navigate this world of the business of medicine. And I want to be able to help you and help you avoid the pitfalls that I've gone through. And feel free to schedule a call with me. The link will be in the show notes. As you know, my objective is to help you practice impossible. And I think learning the tools and learning the things that I've learned over the past couple of years will help you do that. So click on the show notes, schedule a call, and hope to hear from you soon. Thank you so much for listening, and we'll see you next week.
Welcome to the Practice Impossible podcast, where your host, Jude Pierre, MD, also known as Coach JPMD, discusses medical practice topics that will guide you through the maze that is the business of medicine and teach you how to increase profits and help populations live long. Your mission, should you choose to accept, is to listen and be transformed. Now, here's your host, Coach JPMD.
So welcome to the Practice Impossible podcast, and we're into the Money Tree series, number 2, and talking about HMOs. And so I have to say that life happened last week, and I wasn't able to release the second Money Tree series. So it's being released this week. So thanks for listening, and I hope to release the Money Tree series episodes every Tuesday, and still release the podcast episodes every Thursday, and that's every other Thursday. And today we're talking about the HMO, or the trunk of the tree, and how this all works in a Medicare Advantage organization. So 2 weeks ago, we talked about the Center for Medicare and Medicaid Services. That's the root of the tree, and how Medicare receives its monies to fund healthcare in this country for the majority of the 65 and older patients, and how Medicare funds the 65 and older, or the disabled, or those that are on dialysis. And it was enlightening to me to understand that most of the Medicare funding is actually through Medicare trust funds that were set up by Congress, and through taxes, and through medical, or through payroll taxes, and through federal taxes. We have a fund that's able to fund healthcare in this country. But how does an HMO, or Medicare Advantage company, receive its payments? Well, it comes through the Center for Medicare and Medicaid Services. So insurance companies receive those fundings by either providing services as a local organization. So you may be in a county where you have a large penetration of a particular insurance company, and those insurance companies are only local to that state or local to that county. And then there are regional insurance companies, and regional, when I say regional, that may be a whole state or a whole region of the United States. So let's say the Southeast region, or the North Atlantic region. And those insurance companies receive funding in somewhat of a different way, but for the most part, the government pays those insurance companies to provide care instead of providing direct payments to healthcare providers. Most physicians receive money through Medicare by providing a service and receiving monies directly from Medicare. In certain regions and certain localities, those insurance payments can be received through Medicare Advantage companies that receive monies from Medicare, and those insurance companies pay the providers based on contracted rates. So let's focus on Medicare Advantage because that's what we do. We try to teach you as much as we know about Medicare Advantage companies. And so CMS payments are 100% based on a bid that the insurance companies provide to the government that tells the government or suggests to the government this is how much they think that it's going to cost to take care of their population of patients. And then there is also what we call a benchmark that the government uses based on previous data that they have on that population of people in either that county or that region. And then CMS calculates the risk scores for that patient population and multiplies it by that base rate and benchmark. Now, there are other characteristics that CMS uses to pay those HMOs that include diagnoses, like we just talked about with HCCs, and I go in depth into that in the LAMA course, by age, by sex, by Medicaid status, and also by the disabled status as well. So imagine CMS funding as being a pie of payments to payers that's based on a whole bunch of different factors. And those factors are based on a patient population. And the sicker the population, the higher the payments to that HMO. Now, a couple of other things that factor in are the quality scores. The better the quality of an HMO by preventing care, by having patients perform some of the preventative care measures that are required by CMS, those insurance companies may receive a higher payment. And in the document that I'll reference in a little bit, it also describes what we call a rebate to those health plans based on their star ratings. So what I'd like to do with this episode today is to give you 3 things that you should know as providers that could make or break your practice. And so the number one thing, the first thing I want to talk about is that it is complicated. There are accountants that actually train to figure out these numbers. And, I thought about bringing one of those accountants on this podcast, but I think it would be a great episode to help you fall asleep because it is boring. Those number crunching accountants, that's all they do is crunch numbers and look at populations and statistics and think about your statistics classes and how boring they were. At least they were for me. I wouldn't do that to my audience. So I just want you to know that it is complicated, and I'm going to try to kind of make it simple and give you the basics about what HMOs do in terms of the money tree that we've been talking about. Now, I know it's complicated, but the more you know about it, the better choices you can make about your practice. So in the show notes, I'm going to put a link to a document that I use to help prepare for this episode. And it's a document created by MedPAC. And MedPAC is a Medicare Payment Advisory Committee. That's an independent congressional agency that was established in 1997 to advise Congress on issues affecting Medicare. And every year they produce a document, and that document is called the Medicare Advantage Payment System. And they basically revise it every year, I believe in October. And it tells Congress where Medicare Advantage plans stand. And that's a great document. It kind of goes into the weeds a little bit. That's kind of where I got some of this information about how Medicare Advantage companies get paid. So the second thing you should know about Medicare Advantage plans and how they get paid is that they can be regional or local. I kind of discussed that a little bit at the beginning. So think of it as a mom and pop store. So you've got mom and pop stores that are local. They provide services to a local population. They know the members or they know their clients very well. And they provide the things that they would need in that local area. I think they give better service because they have better relationships with their clients. And so it's what we do in Hernando County in Florida. So in Florida, we have a couple of local HMOs that at one point we actually helped start up. We provided networks for them. And it was great to see the growth, great to see patients who actually were appreciative of some of the things that the HMOs, the local HMOs did for them that the regional ones wouldn't do. And of course, there are drawbacks to being local and that some of the higher end services were not able to be provided. But then we lived in a city that was about 45 minutes, or I live in a city that's about 45 minutes away from Tampa. And that allows patients who are in a local HMO that don't have the services of a regional HMO to be able to go out of network and to have services that they would not have been able to have in a local HMO. But yet, if things arise, if patients have complicated diagnoses or complicated cancers, they were able to go to one of our tertiary care centers without an issue. So the nice thing about going to or providing services for a local mom and pop or local HMO is that it's easier to negotiate with them on payments and negotiate on things that you may be providing for that local population that a larger HMO may not have or be willing to pay for. So remember that HMOs bring in a lot of money. And so don't shortchange yourself. So even though you may not understand negotiating and understand all of these things that we are talking about here, we obviously want you to understand them, but understand that Medicare Advantage companies make a lot of money and local ones may be able to help grow your practice and you can negotiate better with them as opposed to regional HMOs where you have a large organization that is looking to expand networks in a region. They may not see you as a local provider being able to provide the services. They may want to go to a larger organization because then they don't have to deal with the individual physicians. So there's some drawbacks to being part of a regional HMO versus a local one, but just know that there is a difference. And I think one of the major differences is that specialists get paid fee for service. And PCPs in local HMOs can and many times get paid a capitation rate. So capitation means that they receive monies every month, regardless of whether they see the patients or not. And they receive bonuses based on the care that they give for the patients and the quality scores and their risk factors or their risk scores. So regional HMOs may not be able to provide that capitation rate because they're just so large. And I believe there's some stipulations from the government that don't allow that as well. But we'll be getting more into that in further episodes as we go into the providers and the branches of that tree. And, I mentioned the payment tree. And so I do want to give you an opportunity. If you didn't hear my first episode on the Money Tree series, there is a download that you can download that references the Money Tree and what I discuss in this series. And that can be found at www.coachjpmd.com/moneytree. So go ahead and download that if you haven't done that already, and so that we can use that as a reference. So the third thing I wanted to talk about, or I wanted to make sure that you understood as providers, is that providing quality and high quality preventative care can help you increase your patient population as well as your revenue. So you have to remember the Medicare Advantage plans are in it to make money. They're private companies that are looking to make money, and they want to partner with providers as well as patients, but they want to partner with providers that can provide quality care because that in turn increases their STAR scores and potential revenue in the future. So providers who understand Medicare Advantage plans and provide high quality Medicare Advantage plans are going to send patients to you. And in order to provide that high quality care, you have to have a good network of providers. I remember going to bat for for a provider that was in the area that wanted to join a local HMO. And I went ahead and talked to the insurance companies because I felt that provider was able to do things that other providers in the area were not able to do. And that allowed me to have a provider that could provide better care for my patients. And that's just basically a win-win scenario for not only the patients, but also the HMO. So to summarize this episode, know that this is very complicated. And I'm trying to simplify it as much as I can. And feel free to download that MedPAC, Medicare Advantage Program Payment System Summary that kind of gives you the details of the things that we talked about today. And the second thing I wanted to make sure that people understand is that Medicare Advantage companies, HMO companies, make a ton of money. And we have to know that as providers. So we can't sell ourselves short because if a Medicare Advantage company makes, let's say $1,000 a month on every patient, yes, they have their costs, they have their marketing costs, they have their costs to remain in business, and obviously shareholders to please. But it always struck me as, Medicare Advantage companies make $1,000 a month per patient. And let's say they have 100,000 patients or 500,000 patients. You can do the math as far as how much they make a month. Them paying a fee-for-service provider $50 per visit is really nothing to them. So I would invite you to understand that you can negotiate rates if you provide a good service and patients like you, and you are compliant in your documentation, and you do the things that are important in any practice. You should be able to negotiate better rates in a Medicare Advantage situation. The other thing you have to know is, Medicare Advantage companies contract with providers directly using fee-for-service or IPA or MSO models to provide care. There can be capitation rates, like we talked about, for local HMOs and for regional HMOs. Those are a little bit different in terms of payments, but still do the same thing. They receive monies from the from CMS, and they distribute those funds to providers. And in the next couple of series, we're going to talk about providers and how they receive monies. So thank you so much for listening to this Money Tree series number 2, and talking about the HMOs. And my goal is to basically help you understand the whole system, and I'm kind of piecemealing this so that eventually, if someone wants to listen to all the Money Tree series episodes and understand every aspect of the payment to providers, you'll be able to do that. Thank you so much for listening to the Practice Impossible podcast, and we'll see you next week. Thank you for listening to the Practice Impossible podcast. And before we start this episode, I wanted to make sure that you guys are aware that, especially those physicians that are overwhelmed out there and feeling not so confident about the practice of medicine, I help you. I help you gain the confidence that you need to increase your income and get back some time. All this within 90 days or less. So book a call with me and learn more about what I do. Use a link at the bottom of the show notes there today. And I'd love to be able to hear what your struggles are and help you decrease your stress and increase your income.
Welcome to the Practice Impossible podcast, where your host, Jude Pierre, MD, also known as Coach JPMD, discusses medical practice topics that will guide you through the maze that is the business of medicine and teach you how to increase profits and help populations live long. Your mission, should you choose to accept, is to listen and be transformed. Now, here's your host, Coach JPMD.
I really love that sound. So today we're going to continue the Money Tree series on the Practice Impossible podcast. And this is episode number 3 in the Money Tree series. And we're going to be talking about IPAs and MSOs, and not the IPA you might be thinking about if you like beer, but it is the Independent Practice Association. That's what IPA stands for in the insurance industry, or MSO, Management Services Organization. So that's the organization that sits in between healthcare providers and facilities and the insurance company. So in episode 1, we talked about CMS and the Center for Medicare and Medicaid Services. That is the root of the money tree. Then we talked about in episode number 2, the insurance company, and that's the trunk, and that's who receives money from CMS. And if you haven't had an opportunity to download the money tree diagram so you can kind of follow along with what we're talking about, you can go to www.coachjpmd.com/moneytree, and you can get a download of that tree so you can follow along in the podcast. So an IPA, or Independent Physician Association, or Independent Practice Association, is an organization that is created to be the somewhat of the middle woman of the healthcare organizational payment systems that can also act like an ACO, or accountable care organization. And what they do is it's formed to help group physicians and organizations together into one contracting entity. That entity can credential you as a provider, or credential healthcare facilities, and can also act as a negotiating body for the insurance company. So if you're in a town or a county or a region where there are not a lot of medical providers or specialists or even healthcare facilities, an IPA can help negotiate better rates for you as opposed to you going directly to the insurance company. The IPA may say it may be able to negotiate better rates. IPAs can also help with the management of electronic health records and compliance and billing records, and as well as provide administrative support to practices that may be starting off. There are things that IPAs can do to help with bulk purchasing of medications, as well as purchasing power for other aspects of your group. And it's just a good way to be a buffer between the insurance company and you as a healthcare provider. So in my practice, we deal with an IPA that helps us manage the capitation checks that come in. So the insurance companies will contract with the IPA, and that IPA will then distribute the monthly capitation checks to each individual primary care provider. And that allows us to not have to deal with the insurance company, and the insurance company doesn't have to deal with us, because sometimes, just as the government doesn't necessarily like to manage individual providers, insurance companies may feel the same way. And one of the things that a good IPA also does is that it can negotiate better rates with the insurance company. There are some insurance companies that can pay an additional premium if you are accepting only one insurance company. Typically, insurance companies will keep 20% of that payment that's made from CMS to the insurance company, and 80% is then distributed to the IPA. The IPA will then take an administrative fee and also provide reinsurance. Reinsurance is something that we talk about in the LAMA course. And what it is if you have a patient that becomes what we call catastrophic, those patients hit a threshold where the payments to the healthcare facilities are above and beyond a certain amount, then the IPA can contract with another insurance company to help cover the costs that are above and beyond that 80% that they're getting from the insurance company. So I'm getting in the weeds here, but just know that there are some benefits. Some of the drawbacks of having an IPA involved in your practice is that you're kind of beholden to them. So if they don't do a good job for you, if they don't negotiate well, and if they don't have a good network of providers, then you can lose your shirt. So it's important to find an IPA or an MSO that can support you, that has experience in supporting you, and that can really have your back as a provider. Another drawback is that they do have an administrative fee. So that administrative fee can cut into your profits. Another thing you might find in poorly run IPAs is the push to not providing the appropriate care for patients. Obviously, whenever a company in the healthcare field has an incentive, if they don't provide care, they make more money, then you can obviously think about what that might do to a company's ability to provide the right care for patients. So it's important for providers to understand and to treat patients first, and to really look at finances as secondary. And I've always felt that is, if you do the right thing in patient care, money will follow. And the key thing is to learn what the right thing is. And that's what I'm hoping we can do with this Money Tree series. So the big takeaway from this episode is to understand that the IPA, or the Management Services Organization, sits in between the healthcare providers, that's the primary cares, the facilities, the hospitals. They sit between them and the insurance company, or the Medicare Advantage company. They can provide some great benefits, especially negotiating better rates. But you have to understand what makes up a good IPA and a good management service organization, and to ask around, because it's important that company has a good integrity and provide compliant and cost-effective care for your patient population. So let me know what you think. This is a third Money Tree series episode, and you can go to www.practiceimpossible.com and leave us a comment. Let me know what you might want to hear more of. And of course, as always, I ask for you to leave a review or some feedback, because it's with that feedback that we can continue to make these episodes more valuable to you and to help you practice impossible. Thanks for listening, and we'll see you next time.
Welcome to the Practice Impossible podcast, where your host, Jude Pierre, MD, also known as Coach JPMD, discusses medical practice topics that will guide you through the maze that is the business of medicine and teach you how to increase profits and help populations live long. Your mission, should you choose to accept, is to listen and be transformed. Now, here's your host, Coach JPMD.
Welcome to the Practice Impossible podcast. Thank you for listening. I'm your host, Coach JPMD. And before we start this episode, I wanted to encourage you to leave some feedback for me. Leave a review on Apple Podcasts or wherever you listen to your podcasts, because that's the only way I'm going to know what you want to hear and if this is resonating with you as physicians or as healthcare providers in the community. And we want to serve you, and we want to provide as much value as we can in these episodes. So today's episode is actually on the money tree. It's a part of the money tree series that I started back in October of 2021, for those of you that are listening in 2022 or beyond. And I have a confession. And my confession is, I think I bit off more than I could chew in saying that I want to offer this money tree series every week, because I just ran out of time. And so I'm going to be inserting the Money Tree series into our bi-weekly releases of our podcast. So that's why you haven't heard a Money Tree series in a couple of weeks. So that's my confession today, because I thought I could potentially keep up. But with the practice and with things happening in life, I found it a little bit more challenging than I thought. That said, I do want to continue the Money Tree series. And today, we're going to be talking about specialists and how specialists and what role specialists play in that money tree. We've discussed the money tree several times, and that can be downloaded at www.coachjpmd.com/moneytree. And just to give you an idea of what I'm talking about, because I keep saying this in our series, and it kind of depicts the flow of monies from Medicare to specialist pockets or primary care physician pockets or hospitals pockets. So we've talked about how the government is funded through tax dollars. And we talked about how the insurance companies receive monies through CMS. And then we talked about IPAs and how they distribute monies to healthcare organizations. So today we're going to talk about specialists and really how they impact the flow of funds within an insurance and an IPA's pool of funding. So when we talk about specialists, we talk about podiatrists. And we had Dr. Jude Farley-Pierre, who's a podiatrist friend of mine, who on the podcast a couple weeks ago. And if you haven't had a chance to listen to that, he talks about some of the things that we talk about in the payment tree and the IPAs. And I encourage you to listen to that episode. And that episode is episode 19. And then you have cardiologists who are contracted to provide services for healthcare organizations and Medicare Advantage companies. You have pulmonologists, you have hospitalists, you have neurosurgeons, you have hand surgeons, you have plastic surgeons. And so all of these specialists contract to provide care in a network of physicians in a particular county. So you may have heard of the term out-of-network providers or in-network providers. And so a specialist, in order for them to accept payments or even to see patients, part of payments from a Medicare Advantage company, they have to be in network. So they have to credential with that particular HMO or that Medicare Advantage company in order to provide services. And those services are usually rendered on a fee-for-service basis. So they see the patients and they provide they complete a surgical procedure and they receive monies from the healthcare plans or the Medicare Advantage companies. Now, as a primary care doctor, it is my job to somewhat be the gatekeeper for those funds. And there are specialists that provide care that's cost effective. And then there are specialists that don't. And after practicing for 20 years and developing a strong network of specialists in our area, I tend to understand who can provide cost-effective care and efficient care for my patient population. And I tend to refer patients to those specialists. One of the beauties of having a network of specialists in your county, in your area, is that you develop relationships with them. And so if you have a patient with, let's say, dysphagia that can't swallow or having, difficulty swallowing solids, I've routinely called my GI specialist, and he's been able to see my patients within a day or two. And having those types of relationships really helps patient care and also decrease costs, because if those patients are not seen in a timely fashion, then they'll end up in the emergency room, which will eventually cost you more in caring for that patient. And so that's typically in a fee-for-service contract. But there are specialists like podiatrists, like my friend Dr. Jude Farley-Pierre, who receive a flat fee for managing patient populations through an IPA. And I can't remember if he was actually doing that or if a podiatry group that he was in was doing that. But insurance companies can contract with specialists who have a group of providers for which they then receive monies, let's say on a capitated basis. So they receive the same amount of money every month per patient. And that enables them to kind of predict what their income is going to be, and also decrease the need for billing for individual services and hiring billing staffs to code for particular procedures, because, the procedures that are performed are part of that arrangement, part of that capitation fee. So the billing is a little bit simpler, or the billing is simpler in terms of collections. So in creating this episode, I wanted to highlight 3 things that specialists can do to practice impossible. And one of the main things is that they need to know their markets. There are some specialists who don't understand that if they go into a community where there are not a lot of specialists like neurosurgeons or hand surgeons, plastic surgeons, they can negotiate higher rates to be able to enter and provide services in that county. So that's one thing. The other thing is you want to befriend the high volume PCPs. There are a lot of primary care physicians that may not be as busy in a community, but those that are busy are going to send patients to cost-effective and efficient specialists. And we try as primary care doctors to decrease hospitalizations and decrease emergency room visits. And to do that, you need a good, strong network of providers that are going to provide care same day, next day. And that allows patients to get the best care, I feel, particularly when patients can get very anxious about certain medical conditions. And the third thing that I would recommend that a specialist do is diversify. So I don't feel that it's a good idea to just focus on one insurance company. Specialists should have multiple insurance payers that they contract with so that they can diversify their income, just like diversifying a portfolio in your 401k or your investments. Because, if that one HMO or the one Medicare Advantage company doesn't do well, then that could affect your revenues. So know your market, know your worth, know your value in that market. Befriend the high volume PCPs because they will send you patients and they will refer patients to you. And diversify. So you guys might be wondering, why does this all matter? It's interesting because last week or a couple of weeks ago, I took a week off and I had the TV on during the daytime hours, and I usually don't, but I had the TV on just for noise purposes. And it was almost as if every other commercial had a celebrity promoting Medicare Advantage plans, from Joe Montana to William Shatner to George Foreman to even JJ Walker. I don't know if our audience is old enough to know who JJ is, but love JJ. And you can look him up if you want to. But, so these are all celebrities promoting Medicare Advantage plans to seniors, because I guess most of them are watching TV during the day. And I kept wondering, as a physician, we should know everything we need to know about Medicare Advantage plans because they're being promoted so much, especially during the open enrollment period, which I believe ends December 7th. So after December 7th, you're kind of locked into a Medicare Advantage plan as of January 1st. So if you are in a population where there's a large Medicare Advantage population and you're practicing medicine, and you're seeing patients over 65, you kind of really need to know what's going on in the Medicare Advantage world, because it is being promoted in the community. It's now, Medicare Advantage is penetrated over 35%, I think almost 40% in some of the numbers that I've seen of patients enrolled in a Medicare are in a Medicare Advantage plan. So we as physicians and as providers need to understand this well. And so that's why I created this Money Tree series. I want to be able to provide that information for you. This was a kind of a short episode, but it is an episode that I think it kind of follows the payment tree and the money tree that I've created. And if you want to hear more, if you want me to go more in depth in some of these topics, leave a review. Visit practiceimpossible.com. Tell me what you think, and we'd love to be able to create more episodes like this, or not. But I only can do that if you tell me. So thank you again for listening. And don't forget to share this with your friends and your colleagues, because that's what's going to get the word out that this exists. And hope you guys have a great holiday season.
Welcome to the Practice Impossible podcast, where your host, Jude Pierre, MD, also known as Coach JPMD, discusses medical practice topics that will guide you through the maze that is the business of medicine and teach you how to increase profits and help populations live long. Your mission, should you choose to accept, is to listen and be transformed. Now, here's your host, Coach JPMD.
Thank you so much for listening to the Practice Impossible podcast, and we're happy to be back. I'm happy to be back after a brief COVID pause, as you heard last week. And I'm resuming the episodes with the Money Tree as I promised. And today's Money Tree episode is going to be on radiology or you could say diagnostic centers, not just radiology, but diagnostic centers and how it affects the payment tree. And for those of you who have not already downloaded the Money Tree diagram, you can do so at www.coachjpmd.com/moneytree. And the Money Tree is basically a diagram that details how insurances, IPAs, MSOs, and primary care physicians get paid, and how different specialties or different providers affect that payment tree. And a lot of this is discussed in the Llama course. In addition, you can book a call with me if you're interested in learning more and how we can decrease your stress and increase your revenue by learning more about Medicare Advantage. I'm happy to have a call with you guys for 30 minutes so we can kind of understand what I do and how I can help you decrease your stress. So when we talk about radiology costs, we really speak about how diagnostic centers and sending your patients to the diagnostic centers can affect the revenue and your bottom line in your managed care panel. It's about patient population management, right? And we talked about how the insurances pay the IPAs, or I should even start before then, but how the government, CMS, pays the insurance companies, the HMOs and Medicare Advantage companies. And then those IPAs that contract with the managed care organizations contract with different facilities and different providers of care. And the diagnostic centers obviously provide services like mammograms, x-rays, CAT scans, MRIs, and hospitals can also do the same, right? Hospitals have radiology centers and radiology diagnostic facilities at their facilities. But these procedures performed at hospitals can cost a lot more than diagnostic centers or outpatient diagnostic centers. And I have an example of that with my son, who is not on Medicare Advantage, but he needed an MRI of his lower extremities. And it was ordered by his orthopedic doctor. And the orthopedic physician or the sports medicine physician wanted the MRI to be done at one of his hospital-based facilities. And the hospital actually owns or employs that physician, and as well as owns the hospitals and the diagnostic centers. So we, because of our deductible plan or high deductible plan and insurance plan that we have through our company, we actually received an estimate for outpatient services. And this was actually pretty interesting because when I looked at the estimate, it was an estimate for the MRI being performed without contrast, so without dye, at a hospital facility. And the deductible amount was $1,471 with a coinsurance of $98, which is, I guess I paid 10% coinsurance. Still trying to figure that out. So the estimated patient responsibility for that MRI at the hospital was going to be $1,569. Now, right next to that estimate was the estimate for a facility owned by the hospital system, which is a freestanding outpatient imaging center. And that deductible amount, which really equates to how much the facility is charging and for that procedure, was $544 with no 10% co-insurance. So my estimated responsibility was $544. So in my mind, I'm thinking, why would I ever want to go to the hospital and have an MRI of my lower extremity done for my son rather than have it done at an outpatient imaging center? I mean, the quality of the MRI is going to be the same. There's really no difference. But yet, because the facility at the hospital, they can charge more for those services. So how does that apply to the Medicare Advantage world? Well, in the Medicare Advantage world, the insurance company, or the Medicare Advantage company, will contract with a diagnostic center and for a certain percentage of Medicare allowable. And so that same Medicare Advantage company will also contract with a hospital system in that particular location or that particular county. And as a primary physician and as specialists, if we don't manage that bottom line, then there's going to be less money in our pockets. That's basically what it boils down to. And so it behooves us to understand that if we send our patients in a Medicare Advantage plan to a hospital, that hospital may end up charging that insurance company $1,500 for an MRI versus $500 that could be charged at a freestanding diagnostic facility. So that is a very important point that I can't emphasize enough, because we as physicians and primary care physicians need to understand how to manage our patient population, how to get them the best care, but also how to provide the most cost-effective care for that patient in your patient population. So that's one way to save money. Another way that you can save money is by doing procedures in your office. So for a while, I actually used to perform carotid ultrasounds as well as vascular studies in my office. And those procedures were performed at no cost to the patients, because I knew that if I were to send those patients for those procedures at a diagnostic center, the diagnostic center would be charging the insurance company, and those monies would be removed from my pool of monies to care for my patients. So again, these things are really discussed in detail in my LAMA course that allows us to actually look at the reports, look at the reimbursements, look at the differences in facilities where these tests are being performed to be able to help you manage your population best. And so having tests performed at an outpatient imaging center will save you money. Having tests performed in your office, like having a bone density machine or having a carotid ultrasound or an echocardiogram, all these tests are performed at your office are performed and are not reimbursed the same way that it would be reimbursed at a diagnostic center. So the only cost that you would have is the cost for the technician, the cost to have the actual machine in your office, as well as the cost for reading those tests by the specialist. So that's another thing that I wanted to bring up during this Money Tree series, because all these things have an effect on your capitation and has an effect on your managed care monies. And the more you know about this, the more potential you have to save money and eventually also make additional funds or have surpluses in your managed care population funding. Now, if you look at the office procedures, you may not only have managed care patients in your practice. So you may have fee-for-service patients. You may have Blue Cross Blue Shield or United or some of the other payers in your community. You may have Medicare in your practice. And those procedures that are performed on those patients that are fee-for-service would actually be reimbursed whatever the Medicare allowable rate is. And that's a great opportunity for you to increase your revenue in your practice by performing those tests in your office rather than having those tests done at a diagnostic center or at the hospitals. So that's something that I used to do routinely. And now we have a centralized testing facility at our current practice, so we don't have to do that. But again, it's another way of potentially increasing your revenue in your practice. So I know this was a short episode, but that's what the Money Tree series are. They're not long episodes. They're episodes that can provide you the nuggets that you need to improve your managed care population funding and also manage your patient population more effectively. And I encourage you to download the Money Tree series one-pager that details the different aspects of the payment tree. And you can do so at www.coachjpmd.com/moneytree. As well as, remember, you can always sign up for the online course at learnaboutmedicareadvantage.com. And the introductory course is free and allows you to get ahead of the game in understanding Medicare Advantage if you don't have any knowledge of it at all. And as always, we always invite feedback, and I want you to share this episode with your friends and anyone that you think might benefit from it. And through that feedback, it allows me to understand what you guys want to hear more about. And I really thank you for listening to this episode, and keep practicing impossible.
Welcome to the Practice Impossible podcast, where your host, Jude Pierre, MD, also known as Coach JPMD, discusses medical practice topics that will guide you through the maze that is the business of medicine and teach you how to increase profits and help populations live long. Your mission, should you choose to accept, is to listen and be transformed. Now, here's your host, Coach JPMD.
You can't say that you don't like that sound. I love it because, it reminds you of when I'm selling things on eBay or OfferUp, and you hear that sound and monies are coming in. So welcome to the Practice Impossible podcast with your host, Coach JPMD, and I'm here to talk to you today about ambulatory surgery centers. Now, this is a continuation of our Money Tree series episodes where I kind of describe what you can do in your managed care practice to save money. And if you haven't downloaded the Money Tree diagram, I suggest that you do so you kind of know where I'm going and how things are flowing. And you can do so at www.coachjpmd.com/moneytree. And you can follow along there. I've released a couple of episodes already. And if you scroll down through the list of episodes, you'll see them marked differently with the Money Tree in the title of the podcast episode. So, ambulatory surgery centers are medical facilities that provide the same-day or outpatient surgical procedures. Some people call them surgery centers. They're usually certified by the government to provide medical services and usually surgical services. And one of the things that you can't have in a surgery center is a mix of functions between a primary care physician's office and a surgical suite. Another thing that you can't have is that the ambulatory surgery centers cannot share the same space with hospital outpatient surgery departments. So they're essentially standalone surgical facilities that sit in communities that perform services, and Medicare Advantage companies will contract with ambulatory surgery centers for many different reasons, but the main reason is to help save money, save costs in caring for patients. A lot of times surgery centers are managed patients and they have lot shorter stays. There's less complications or infection complications. And, as we talk about money in our Money Tree series, they also save money. So when you look at hospital procedures versus procedures done at ambulatory surgery centers, some of the costs could be double. So I remember receiving a referral authorization request from a specialist or an OBGYN in the community, and it was for a gynecological procedure that they're requesting to have the procedure done at a hospital. And I denied the procedure. And one might say, well, why are you denying procedures at hospitals? Well, as a primary care physician, I'm supposed to be managing a patient not only on the medical side, but also the financial side in a managed care environment. And some might say that physicians shouldn't be involved in that, but I say differently, because if you look at the monies that are distributed to your managed care panel to manage your patient population, there are some patients that are much sicker that may need those funds that may be funneled or spent on surgical procedures performed at hospitals that could be going to patients who need transportation to the office. So that one procedure, I had the office call the gynecologist, and their response to me was that the surgeon didn't have privileges at any of the local ambulatory surgery centers, which was hard for me to believe. But I guess if a surgeon is in a community where they perform most of their procedures at the hospital, I could certainly understand why they would be more convenient for them to have all their procedures done in one place. But I think specialists in this day and age need to understand what and how this can benefit the patients as well as benefit your primary care referral base. So one of the things that we like to do is partner with specialists who have privileges at surgery centers so that we can save overall healthcare costs. And that's just something that we do, and something that I think is important for physicians to know coming out of a residency, and to understand how doing certain things at different procedures or at different locations can affect that payment tree. And I think as physicians, we are leaders in healthcare, and we're leaders of our patients, leaders of our team members, and leaders in the community as a whole. And when you look at the cost of sigmoidoscopies performed at hospitals, outpatient departments, according to Healthcare Cost Institute, it's an online resource that I actually found, and I'll share the resource link at the bottom of the podcast. But sigmoidoscopies performed at hospitals can cost on average $1,285. It's $1,285. While if performed at the office or a surgery center, it could cost on average about $174. So think about the cost of the overall healthcare expenditures when more procedures are performed at the hospitals. And, I always say that if the procedures are done at the hospital, that takes away, especially routine procedures, but, that takes away from patients who are really sick in the hospital that need bigger procedures, that need the resources of the hospital system. So I think before you schedule things that can be done at ambulatory surgery centers at hospitals, it's certainly important to look at how that affect overall costs of care, and essentially how, affect the payment tree, because that's what it's all about, right? It's about looking at ways of performing cost-effective care. And this shouldn't mean that you are skimping out on care and performing procedures at the surgery center that shouldn't be performed at surgery centers. But it's something to consider in the overall cost of healthcare and how we can improve patient care, decrease your practice stress by potentially increasing your referral base with physicians who understand the benefits of this effective nature of managing care, and potentially generate more income for you. So as you know, most of the Money Tree series episodes are shorter and really geared towards helping you understand how to increase your revenue and decrease your stress by lowering costs of healthcare and providing cost-effective care in ways that you may not understand or may not have been taught in the past. It's not all about seeing tons of patients a day, 20, 30, 40 patients a day. It's about managing your patient population and providing cost-effective care. And that's what we do in managed care. And I hope these series will help you understand that a little bit better. Now, if you want to hear different topics, or if you want to follow us on Instagram, you can do so at coachjpmd.com. You can also scroll down in your favorite podcast listening app and leave a review. Let us know what you think. We're in the process of getting some resources together that will help you understand how you can retire early. I'm hoping to be able to show you guys how to do so in 15, 20 years or less. And I think that is possible when you do the right things early on in life. So, and that's not like what I did in life. So if I can show you things that I wish I could have done 20 years ago, I will certainly love to share that with you. And that's coming up soon. So like I said, leave a review, and we hope to see you in 2 weeks. Share with your friends, and be safe out there. Hello out there, my friends. Welcome to the Practice Impossible podcast with your host, Coach JPMD. And today's episode was actually recorded in a hotel room. And there's a backstory to that, of course. And we are actually spending some time in a hotel room with 2 bedrooms, 2 baths, waiting for our home to finish construction. And it's been a little challenging finding a place to record and to prepare for our podcast series. But I wanted to stay true to releasing an episode every 2 weeks. And so here we are.
Welcome to the Practice Impossible podcast, where your host, Jude Pierre, MD, also known as Coach JPMD, discusses medical practice topics that will guide you through the maze that is the business of medicine and teach you how to increase profits and help populations live long. Your mission, should you choose to accept, is to listen and be transformed. Now, here's your host, Coach JPMD.
We're here with the Money Tree series. This is the 7th episode in the Money Tree series where we discuss things that affect your payment tree. And if you haven't had a chance to download the Money Tree diagram to kind of see and follow where we're going and what we've done, you can do so at www.coachjpmd.com/moneytree. And in addition, if you're in an area that has a high Medicare Advantage penetration, I wanted to offer you an opportunity to speak to me by booking a call and following the link at the bottom of the show notes where we can discuss things that might be pertinent to your move or your practice or the patients that you see is really where your focus should lie. So if you're going to be in Michigan or Connecticut, Alabama, Georgia, or even Rhode Island, these areas have almost a 50% penetration, or 50% of patients that are enrolled in Medicare are enrolled in a Medicare Advantage plan. So if you are going to be practicing in those areas, you really need to understand that demographic and those insurances. So that's what I've been doing with the Money Tree, is kind of bringing awareness to that. We recently had a doctor from Michigan who worked at the University of Michigan, and on our last episode, who stated that she didn't have a lot of patients with Medicare Advantage because she was working in an academic setting, and she was out of network with them. So if you're in an academic setting, that may not apply to you, but if you are going into the community in these 5 states, you kind of have to know that this is what you're going to be seeing, and this is what you need to understand. So I encourage you to book a call with me. Follow the link at the bottom of the show notes to kind of describe or let me help you understand where your knowledge gaps may be and where I may be able to help you understand Medicare Advantage better and give you the resources that would help you succeed in your practice. So today's Money Tree series is on labs, and it's just another branch of the Money Tree. And just like episodes 13, 14, 16, 20, 24, and 27, 14, we talked about Medicare Advantage plans. Episode 20, we talked about specialists, and episode 24, we talked about diagnostic centers. 27, we talked about ambulatory surgery centers. And all these things affect the payment tree and how a primary care doctor receives payment from a pool of money. But there's also the fee-for-service providers like the specialists and now like labs. So laboratories like LabCorp, Quest, or other independent labs around the country will contract with a Medicare Advantage company to be able to provide laboratory services for their patient population. Many of those services are provided on a capitation basis, and we touch on capitation in our LAMA course, as well as some other episodes where a laboratory company will receive a set amount of money per month per member to be able to provide services. So if you have a population of 1 million people under a Medicare Advantage plan, then that capitation payments will be based on that population and the demographics of that population, how sick that population is. And they will provide services like lipid panels, CBC, CMP, and other routine testing where patients can go as many times a year, and they will get, the insurance company will reimburse the laboratory the same amount regardless of how many times they go. Now, if it's a specialty test, like a vitamin D 25 hydroxy level, or an ionized calcium level, or specific pathology services, or even urine drug tests, those tests are usually not covered in under capitation plan. So every time you send the patient for those tests, then they will affect that payment tree. So it will remove monies from the pool of money that you have to take care of those patients. So if you know anything about insurance contracting and getting payments from insurance companies, it's a volume game. It's about making money on the volume of patients that you're going to see, because if you can see a large volume of patients, then your costs may go down for taking care of that patient population. But also it's about exclusivity. So if you are a company like LabCorp or Quest, most insurance companies will not contract with both of those major payers. Most of the insurance companies will not contract with both of those lab companies, I should say. They'll contract with one for that exclusivity. They'll maybe get a discount for that patient population that they're going to be guaranteed to make money on. And it's a win-win for both parties usually, whereas the lab company knows that if they have a population, like I said, of 1 million patients or 5 million patients, and they're charging them $1 per member per month or 50 cents per member per month, whatever that contracted rate is, they know that that income will be steady based on the patient population. Now, on the insurance company side, the insurance company will then know every month based on their population of patients, they're going to pay that lab company X amount of dollars per month, and they don't have to worry about fluctuation of expenses. And that's why a capitated model sometimes works better than a fee-for-service model. And obviously, you can have carve-outs. You can have things that can be paid extra and negotiated for a higher amount in order to make that agreement even a better financial arrangement for both parties. So this is a relatively short episode on laboratories and how they receive payments and how it affects the payment tree. And if you like these Money Tree series, leave a review for me. Let me know what you think. If there's other things that you want me to talk about, for sure that I would be open and willing to insert them into the queue of episodes to come. Don't forget to download the Money Tree diagram at www.coachjpmd.com/moneytree. And those links will be at the bottom of the show notes. And we thank you for listening and hope you enjoyed this episode. And like I said, leave a review and we'll see you soon.
Welcome to the Practice Impossible podcast, where your host, Jude Pierre, MD, also known as Coach JPMD, discusses medical practice topics that will guide you through the maze that is the business of medicine and teach you how to increase profits and help populations live long. Your mission, should you choose to accept, is to listen and be transformed. Now, here's your host, Coach JPMD.
Welcome to the Practice Impossible podcast with your host, Coach JPMD. That's me. And if you have heard any of the Money Tree series episodes before, you know that I love that sound because that means that we're going to be talking about money. So today's Money Tree series is on hospital expenses. And as you know, we started this series a couple months ago to detail how monies flow from the government to your pockets as primary care providers, as specialists, as ambulatory surgery centers, as hospitals. Today, we're going to be talking about hospital expenses and how it impacts the revenue stream of a managed care panel or of a patient population in the managed care world. If you haven't had a chance, go to www.coachjpmd.com/moneytree and you can download the PDF of the Money Tree and the flow of what I've described in the previous episodes. So I'm not sure if in previous episodes I've talked about the 80-20 rule, but the 80-20 rule is is the Pareto principle, which kind of states that 80% of your efforts will lead to 20% of your results. And that's true for many things in the world of finance, in the world of the efforts that you produce. And in the hospital expense world, 20% of your patient population will account for 80% of the expenses out of your managed care panel. And that is a rule that I've seen over the past 20 years applied to my Medicare Advantage panel. And hospital expenses are big expenses. And so if there's any way for you to help decrease hospital expenses in your Medicare Advantage practice, that's where you're going to make a lot of money, or at least save a lot of money in your managed care population. And so if you save money in the Medicare Advantage world, then that means more money is going to come to you in your pocket when the pool of monies are distributed at the end of the month. So in the course on learnaboutmedicareadvantage.com, I described what a medical loss ratio is. And I bring up medical MLR, or medical loss ratio, which is the total expenses paid for services in a Medicare Advantage world that's divided or that's over the premiums paid to the insurance company. So what does that mean? So if you understand the medical loss ratio and you understand that 20% of your hospital expenses accounts for 80% of the monies that are flowing out of your managed care population, you'll understand that the ratio that you want your medical loss ratio to be low. So you want your medical expenses for services to be much, much, much lower than the total premiums paid by the insurance company for services rendered, because then that means there's more money to care for other patients in your managed care panel. And it allows you to also receive bonuses at the end of the month. So in order to decrease the total expenses or your medical loss ratio, you want to do a couple of things in your practice. And what I'm going to do is describe 5 things that you can do in your medical practice that can help improve your medical loss ratio and increase your bottom line revenue or top line revenue in your practice, improve your bottom line, I should say. So there's decreasing ER visits. So how do you decrease ER visits in your practice? Well, one of the things you can do is be available. If you're never in your office and you're only working half days, or you're only in the office a couple of days a week and your patients are sick, if they know that you're not available, or they don't feel as though you're available, then they are going to go to the emergency room. And as you know, as primary care providers, if your patients hit the emergency room, many times they get admitted to the hospital, which will increase your medical expenses, which will contribute to an increase in your MLR. So one of the things I do in my practice is have a triage protocol. So I decrease ER visits by becoming available, making myself available, but we also have triage protocols that allows patients to speak to the provider or a nurse or someone that's knowledgeable in the practice that can help decrease the anxiety of patients so that they don't go to the emergency room. So triage protocols are really important things that at least we do, where if a patient calls with specific complaints, we get the providers instantly, and we try to bring them into the office as quickly as we can. I kind of said the third thing in the first thing. So decreasing ER visits by making ourselves available. That's number 3. Make yourself available, even if you're not available in the office, but at least be responsive to your patients if they call the office and want to be seen or heard. Because a lot of times when patients hear your voice as a trusted provider, then they won't go to the emergency room. Fourth thing is decrease the length of stay by staying involved in your patients while they're in the hospital. So one thing that we used to do, and I'm hoping to implement in the near future with my new hire, is a way of following patients that are in the hospital on a daily basis. What does that mean? So if you're a primary care provider and you don't go to the hospital to see your admitted patients, you probably have a hospitalist that's seeing your patients. Well, sometimes there are things that are done in your office. You may know the patient. You may know the patient's family. Family's better than the hospitalist. And just being involved in their care will allow you to help decrease the length of stay, thus decreasing the expenses and improving your medical loss ratio. So that's number 4. And number 5 thing, and there's more, but I'm just listing 5 today, is see your patients once they're discharged from the hospital. So if a patient goes to the hospital, you follow them every day in the hospital through a phone call, through consultation with your primary care, with the hospitalist, that is, or with a specialist. As soon as they get discharged, bring them into your office so that you can then follow up with them and decrease the risk of them having a readmission, which would then increase your medical loss ratio and increase your expenses. So those are the 5 things that I feel that you can do to help decrease your expenses, because hospital costs are the biggest driver of medical care in a managed care population. And like I said at the beginning of this episode, you can download the money tree diagram with all the things that we've discussed in previous episodes. And if you go through the list of the podcasts, you'll see that every money tree series has it labeled as the money tree and the subject that's being discussed on there. So again, it's www.coachjpmd.com/moneytree. I'll have links to that diagram, as well as links to the course that you can look and even take a free course, because our goal is to help you practice impossible, is to help you understand the business of medicine, help you decrease stress, increase your revenues. I know it sounds like a mouthful, but that is my mission, is to help you as primary care providers, as specialists, as care providers in the managed care space, is to help you understand this world better. So thanks for listening. Thanks for leaving a review. Thanks for helping me on this journey. And we'll see you in 2 weeks. I used to think, hey, you know what? I'm not going to see this doctor in the community because he's my competitor, or he may be taking patients from me, but I learned early on by Dr. Singh, actually, who was in our episode on real estate. He taught me a valuable lesson, and that was meeting other primary care doctors in the community and talking to them gave me an opportunity to learn from them, see what they were doing right, see what they were doing wrong. Sometimes they needed coverage. Sometimes they wanted to relate with certain things that I was doing in the practice or in the hospitals. So it's always good to remain relational, especially with your colleagues. Hello out there. Thank you for listening to the Practice Impossible podcast with your host, Coach JPMD. That's me. And this week's episode, as promised, is on the money tree. And if you've been following, I've been releasing the money tree series every couple of weeks on things that you can do in your Medicare Advantage practice to generate funds, decrease expenses, and earn a good living while taking care of your patient population. And this week's episode is on 7 things that you should not do as a PCP or a primary care provider. So you may have already downloaded the money tree diagram at www.coachjpmd.com/moneytree. But if you haven't, do so now so that you can understand how the primary care provider or the PCP is really centered to what happens in the managed care or Medicare Advantage world. So these are the 7 things that you should not do as a PCP. So after I've listed out the 7 things, I'm going to give you some stories that are pertinent to these 7 things, as well as things that I wish I could have done differently as well. So number 1, don't limit the insurances that you take. Number 2, don't refuse to meet other primary care providers in the community. Number 3, don't demand the highest salary coming out of residency. Number 4, don't act like you know everything. And number 5, do your best to not be tempted to buy that fancy car coming out of residency. Number 6, do not plan to pay off your student loans in 25 years. And number 7, don't think that there is not enough patients for you to earn a good living with. So that's the 7 things. So what do I mean by limiting yourself in the first thing, for limiting your insurances that you take when you first start? When I came to this area, I came on an income guarantee, and I needed to make a certain amount of money in order to pay off, or at least not accept as much money coming from the hospital system. And so in order to do that, I need to see a lot of patients. But if you need to see a lot of patients, that means that you probably need to market the heck out of your practice, or you need to accept all the insurances that are offered in the area so that you have the biggest opportunity to see a large panel of patients. So I accepted all insurances, even insurances that many physicians may not think are lucrative. I did that also because I wanted the experience. I wanted to be able to see as many patients as possible. And I remember one doctor, actually Dr. Rayan, who was seeing a lot of TRICARE patients. I think TRICARE Prime was the insurance and at the time, and not many providers accepted TRICARE Prime. So that was an opportunity for me to accept a group of patients that did not have primary care doctors that accepted that insurance. And it turned out to be really lucrative for me. And I don't want to say lucrative, but it was good for the practice. We may not have made a lot of money on TRICARE Prime, but those patients stuck with me for a long time, and they ended up becoming patients that had Medicare or converted to Medicare Advantage plan. So I say take as many insurances as you can, especially when you start off. And then, as you get more comfortable, as you see more patients, as you grow your practice, you may be able to cut back on the insurances that you accept if that's something that you want to do. But initially, don't limit yourself. Number 2, don't refuse to see other primary care doctors in the community. I used to think, hey, you know what? I'm not going to see this doctor in the community because he's my competitor, or he may be taking patients from me. But I learned early on by Dr. Singh, actually, who was in our episode on real estate. He taught me a valuable lesson, and that was meeting other primary care doctors in the community and talking to them gave me an opportunity to learn from them, see what they were doing right, see what they were doing wrong. Sometimes they needed coverage. Sometimes they wanted to relate with certain things that I was doing in the practice or in the hospitals. So it's always good to remain relational, especially with your colleagues. I remember, passing some physicians by in the hospital lobbies, and they wouldn't even say hi to me starting off. And I thought, hey, what did I do to them? But I really didn't do anything because those physicians weren't relational. But there are other PCPs that I developed very good relationships with initially in the practice, and many of them who did not accept certain insurances would send patients to me, knowing that I was relational, I was conversational with them, and I wasn't afraid to meet them and relate with them. So I think one of the things that you should not do, as number 2, is refuse to meet other primary care providers and remain relational with them. Number 3, don't demand the highest salary. Now, I know that some physicians out there are saying, well, I deserve it. I have all these student loans. I need to make as much money as possible. But as a primary care provider, especially in a managed care setting, you may not see those funds or that the revenue coming into your practice until you've grown the practice, until you've learned the things that you need to learn, especially in managed care. Your panels may start off very small. So you don't want to keep yourself in a deficit or keep yourself in a situation where you're having to see more patients to be able to make the salary that you're making. I say, if I were to do it again, I would probably take a lower salary, but a pretty hefty bonus structure. I would negotiate a higher bonus structure so that if I do well, then I will take a higher bonus, which would and could actually earn you even more money than if you were to take a high salary where a practice may have to carry you until you get to a point where you're making enough revenue to cover your salary and your overhead. Now, one of the other things that is kind of tied into that is if you take a lower salary or you're not earning as much initially, but you make yourself valuable to the practice. If there's an extra call that you can take, if there's an extra overnight call that you can take, if there's a nursing home that you can round in to help the practice, if there's an extra walk-in slot or a Saturday walk-in clinics is what I used to do. And when we first started the practice 20 years ago, you make yourself valuable to the practice. Then when it's time to negotiate a higher salary as you grow your practice, it's going to be much easier for your employer to say, hey, you know what? You may not be seeing as many patients, but you're providing a value to the practice. And that in turn will help you generate more money than if you were to ask for a high salary and not be as valuable to the practice. Now, if any of you have been practicing for more than 5 seconds, the practice of medicine is a challenging practice. We come out of residency thinking that we know everything, and we really don't know anything, especially on the business of medicine, unless you had an MBA or unless you had a family member that was practicing medicine. So we have to teach our colleagues coming out that they don't know everything. And it's important to be humble. I think that's one of the things that I think physicians need to consider is to learn from others and to put others ahead of themselves so that they can not only be better practitioners, I think, but it also invites other people to help you. Now, if you come out thinking that you know everything, then why would another physician want to help you? So don't act like you know everything is number 4. Number 5, and this may be controversial, but I'm going to say don't buy that fancy car when you just come out of residency. You got to avoid that. Unfortunately, I did it. I don't know if ever you guys know the movie The Saint with Val Kilmer. And in that movie, I can't remember when that movie came out. I'll maybe put it in the show notes so I can remember it. But Val Kilmer was driving a Volvo C70, 2-door, and it was a 2-door hardtop, I think it was. And after seeing that movie, I think I was in 3rd or 4th year residency. I said, I need that car when I graduate. And I ended up getting that car. Now, I was somewhat smart and I bought it used, but it was still expensive and I had a payment on it. And it was just something I should not have done, knowing that I owed over $150,000, $200,000 in medical school debt. Buying a Volvo C70 that Val Kilmer drove was not the smartest idea. And I know that many do it. I know that many people buy even more expensive cars. But I really strongly recommend that wait 3 years. Don't have doctoritis where you feel like you deserve to have that fancy car, that beautiful house. And because if I would have paid off my debt within 3 to 5 years, which is number 6, then I would have had the opportunity to buy 2 C70s. Not that I think I would want 2 C70s, but it's just something that I think physicians need to be encouraged that they can have and will have the opportunity to buy just about anything that they want based on the income that can be generated from their practice, especially in a Medicare Advantage practice. So number 5, don't buy that fancy car when you come out of residency. That's just something that you shouldn't do as a PCP. But anyway, number 6, don't plan to pay off your student loans in 25 years. That was something else I did. It took me over 20 years to pay off my student loans, all the while buying houses and flipping them in the early 2000s and thinking that I was going to be a real estate mogul. So I said, I don't need to pay off those student loans because, I can make 10, 20% interest on investments. So my suggestion is that we don't hold on to those debts for 25 years. Get them paid off as quickly as you can so that you have the freedom and the ability to do more with your income and invest more and really live freer without debt. And so the number 7 thing that you should not do is think that there is not enough patients to go around. Now, what do I mean by that? Well, I remember Dr. Singh once told me that there is no dearth of patients, that you don't need to have 3,000 patients on an insurance panel or in your practice panel, because I can show you, and I have shown you in the Llama course, that you can make a very good income with about 400 patients, 400 Medicare Advantage lives, that will be more than enough for you. So yes, could you do more with 3,000? Sure. But then you have to understand what your lifestyle is going to look like. You have to understand the overhead that's going to cost to manage those 3,000 patients. And knowing how I grew my practice, knowing how I was able to manage the panel of patients that I've had and that I continue to have, if you do a good job in a community and you partner with your PCPs and you're humble and you do some of these other things that I suggested in this episode, then you will have enough patients. I promise you that. And I don't like promising because you can't really promise, but if you do certain things, and if you understand the business of medicine, and if you understand how to relate with your patients and relate with other colleagues, then that 400 patient population is really nothing for you to have. And the beauty of managed care in this day and age is that if you manage it well, you can also sell your practice in 5-10 years from now for a very good sum of money. I know a primary care doctor in the recent past that I believe sold their practice for 10 times multiple. So whatever their revenue was, they sold it for 10 times more than what that revenue per year was. And there are different formulas of selling your practice, but managed care practices are being bought up by private equity firms. Not to say that that's what we're going to do or that's what I'm suggesting, but that is a way of practicing impossible, right? Because if you want to build a practice and you want to do it well and you want to manage your patient population well and you keep your patients out of the hospital, then you have an opportunity of caring for a population of patients that will be loyal to you, that will stick with you, and that will follow your direction. And you have the opportunity to sell the practice if you want to sell the practice in the future. And this is different than a fee-for-service practice because most fee-for-service practices cannot command such a high multiple in an exit strategy. So that's it. So those are the 7 things that I don't want any of you guys out there doing. I want you guys to practice impossible. And just to recap some of these things, I'm going to go through my notes here real quick and say, number 1, don't limit the insurances that you take. Number 2, don't refuse to meet other primary care providers. In other words, be relational, talk to them, learn from them. Number 3, don't demand the highest salary coming out. Show your value, show your worth, make more in bonuses. That's, I think, the way to go. Number 4, don't act like you know everything. Be humble. Number 5, as tempting as it is, making double, triple of what you've made in residency and fellowship, don't buy that fancy car. Wait, pay off your debt as quickly as possible. At least number 6, of course. Don't plan to pay your student loans off over 20 years or 25 years. And last but not least, there is enough patients for you out there, especially if you can manage them well. You can do so very well with 400 managed care lives, and I can show you that. Book a call with me. There would be links at the bottom of the show notes, as well as, take the course, the Llama course. LearnaboutMedicareAdvantage.com is the website. And I think you'll learn lots of information there. So leave some feedback, share this episode with your friends, and hopefully you won't do these things that some of which I did early on in my career, and it'll accelerate your growth and help you practice impossible. Thanks for listening. Thanks for sharing. See you in 2 weeks. So if you hear that sound, you know that we're going to be talking about money in the Money Tree series. It's a series that I set up, and actually we're completing with this series, or completing the series with this episode on pharmacies. And, why am I doing all this? Why am I doing the Money Tree series? Why am I creating this podcast? And I think one of the things that has intrigued me is, as far as the business of medicine is concerned, is how much physicians and healthcare providers, nurse practitioners, physician assistants don't really understand the business of medicine. My wife loves Hallmark, and she watches the Hallmark channel, especially during the Christmas season. And you cannot watch a show or a movie without seeing tons of Medicare Advantage commercials. We're in the middle of open enrollment, and patients are signing up, and we need to understand what they're signing up for. And I think one of the things that I've done is created this series, and I'll kind of summarize that when we get back after the intro.
Welcome to the Practice Impossible podcast, where your host, Jude Pierre, MD, also known as Coach JPMD, discusses medical practice topics that will guide you through the maze that is the business of medicine and teach you how to increase profits and help populations live long. Your mission, should you choose to accept, is to listen and be transformed. Now, here's your host, Coach JPMD.
So welcome back. So, today's episode is going to be on the pharmacy and how it affects the payment tree and the costs associated with it. This is a difficult topic, so I'm going to try to summarize things as best as I can. And some of the details of the aspects of the pharmacy payment and how it works in the Medicare Advantage realm is in my course on Medicare Advantage. And you can always sign up at www.learnaboutmedicareadvantage.com and sign up for the free course. And there you'll find some more in-depth details about the pharmacy expenses and how that affects your reimbursement and your revenue. So pharmacy expenses. So how does this all work? Pharmacies are everywhere. You've got a CVS, Walmart, Walgreens, Publix. They all have pharmacies, and they're all competing for the business of your patients. And one of the things that you have to understand is that Medicare Advantage plans receive monies from CMS to purchase drugs or to reimburse patients or pharmacies for drugs that are dispensed by physicians. And so CMS gives a set amount of money per patient, depending on the acuity of that patient or the disease processes that the patient has. And that's and the money's given as part of the Part D payment to the health plans. So CMS gives this Part D amount based on actuarial data from people that are much smarter than I am, who come up with these numbers to reimburse or to distribute monies to health maintenance organizations, HMOs, Medicare Advantage plans, right? And these monies are then distributed based on the contracted rates that the pharmacy benefit managers negotiate with wholesalers, with retail pharmacies, with manufacturers. And it's a whole complicated reimbursement system that's so complicated that I had to find a diagram that actually details all of these things. And I'll share that in the show notes. But one of the resources that I used to understand how this all works is through the Drug Channels Institute. And they came up with a U.S. distribution and reimbursement system that kind of organizes the whole patient-administered outpatient drug product flow, financial flow, and contract flow. And I'll share that in the show notes. I don't want to get into the weeds in this podcast, but I basically want to detail how we as physicians can save monies when we are taking care of our patients in the managed care world. One of the things that you have to understand is that brand names medications are going to cost the health plans more. And of course, if the patient needs these brand name medications, then do prescribe them. I'm looking at a screenshot here of Eliquis on GoodRx, and some of the pharmacies are charging retail price of $635. Discounted costs are $553. So if you have a member that's on Eliquis and they're needing this every month, that expense is going to go towards that patient's benefits that are given to them by the Medicare Advantage plan. So if, let's say, the benefits for that member is, let's say, $5,000 a year, well, within how many months? 10 months? 10 months, then that patient would have used up all of their benefits, and their costs are going to go up unless they reach a catastrophic phase. And that's another thing we can talk about, and we do talk about that in the course. That's called a coverage gap, or the donut hole, they used to call it. And so what if we prescribe a generic medication? Well, if you prescribe generics, let's say you have a patient that can't take Eliquis, doesn't want to take Eliquis, can't afford to take Eliquis because of the copays, then you can prescribe warfarin. We have our warfarin clinic in the office, and the patients really don't have to pay anything to get their labs drawn, and we're able to manage their PT-INRs in the office and with no copays for the checks, and they usually don't have a copay for generic medications, which allows the patient to not have to spend as much money. Now, sometimes you may say, well, it's Eliquis may be a better drug, Pradaxa may be a better drug, or whatever the anticoagulant is. But if the patient's not taking that drug because they can't afford it, then what's the point, right? So another way to help save the patient money, which will in turn save you money, is to prescribe generic medications like we just talked about, but also to have patients pick up those medications from Walmart. Walmart has a $4 prescription drug plan that includes some generic medications that patients may already be on. And some of those medicines includes gemfibrozil, fenofibrate, atorvastatin, some of the diabetes medicines. I'm looking on this website here: glimepiride, glipizide, metformin. All these are $4 drugs that are available. And if the patient pays $4, then that won't go towards their pharmacy benefit from the health plan, which will in turn help you save money. Another way is samples. So let's say a patient has to be on Eliquis and you want to support them because they don't have the ability to come to the office or get their INRs checked. Then what you can do is give them samples of medications, which we sometimes do in the office, which will offset the cost. And if you give patients samples of medications, then that does not go towards the patient's Part D plan and thus saves money. So that's just another way. I was looking at Publix. I didn't know this, but I just, in doing research for this course, Publix used to actually give free medications, free antibiotics, free metformin. I have a family member that lives in Haiti, and she would come and visit us, and she's on metformin, and we used to get metformin for her from a 90-day basis, 90-day prescriptions, but they did away with that program. So as of June 2022, it looks like. So Publix no longer has the free list of medications. But there are some other pharmacies that might have that. So again, it's about doing some research for your patients and allowing them to get generic medications if they can't afford or can't take the brand name medications. So that's another way. So depending on the health plan, different health plans may provide different benefits for the members and for the patients. So sometimes patients may switch medication or switch health plans to get better drug benefits. But with that may decrease other services or other things that they may be getting from that one plan that they're switching to. So this is a time that patients enroll in different health plans, looking for better benefits. And the goal is to understand this process and to kind of understand what patients are going through on a yearly basis. Because if we understand it better, then we can serve our patients better, and we can understand and have empathy for them in terms of the medications that they may be wanting to be on or be off of based on different reasons. So I hope this Money Tree series helps you in understanding what we do in managed care and how monies are distributed. And if you want to see the full diagram, you can go to www.coachjpmd.com/moneytree, and you can get a download of that. And we're winding down this year, and we've got some exciting things coming down the pipe. A great interview. My first video interview podcast is coming. So stay tuned for more, and we hope to see you in 2 weeks.